Okay, it's my pleasure to introduce the next speaker, Dr. Altalhb, and he's from Saudi Arabia. He will present a talk on risk factors of infection post non-cultured melanocyte, keratinocyte transplantation for vitiligo. So this is related to the non-cultured cellular suspension technique. Please go ahead.
Hello. It's my pleasure to be part of this amazing symposium. And I would like to thank the organizing committee for giving us the chance to present our work. So we'll talk about risk factors of infection post non-cultured melanocyte keratinocyte transplantation for vitiligo. Nothing to disclose relevant to this presentation. So as we know, non-cultured autologous melanocyte keratinocyte transplantation, or what we call it MKTP, is considered a safe and effective treatment option in stable vitiligo. As we know that it cannot be used for patients with any signs or symptoms of activity from 6 months. Some authorities, they say 1 year or 2 years. And the side effects, including soft tissue infection, has been reported. However, the data about the risk factors of infection are lacking. So many publications were talking about this procedure and some modifications on like preparation of the donor or of the recipient area, but there is no, up to our knowledge, any article is talking about the risk factors of infection specifically. So the aim of this study is to evaluate the risk factors of soft tissue infection following MKTP. It was a retrospective, multicentric study, including vitiligo patients who had non-cultured autologous melanocyte keratinocyte transplantation. The data was collected from National Center of Vitiligo, where I work in Riyadh, Saudi Arabia, and the dermatology department at Cairo University with our colleague in Egypt between January 2010 and September 2020, so it's almost 10 years. A total of 672 patients were included, and almost 70% of them were female. Almost half of our study population were aged from 20 to 30 years, and the mean was almost 25 years. Infection was present in almost 6% of patients. The following factors were independently associated with higher rate of infection, which include cryotherapy for recipient area when we compare it to dermabrasion. So in this study, we compared the cryotherapy versus dermabrasion versus laser. Also trunk, lower extremities, and foot. All these recipient area were associated with higher risk of infection. So infected area, as we know, it will appear as having some pus or dry yellow crusts, erythema, pain, and if we take swab, it will be a positive for bacteria. So as we can see here, this is the univariate analysis, and we can see here some of the factors that was associated with higher risk of infection, including size area more than, the treated area more than 20 square centimeter. Also, if the patient underwent cryotherapy for donor area preparation, they carry more risk of infection. Also, the site of treated area, including head and neck, trunk, lower extremities, hand, and foot, was also associated with higher risk of infection. In the multivariate analysis, the positive factor was cryotherapy. It was independently associated with higher risk of infection. Also, the site of treated area, including trunk, lower extremities, and foot, were also associated with higher risk of infection. So in the literature, the higher risk or the higher infection rate was reported when the recipient area was prepared using cryotherapy. In that study, the infection was almost 30% with cryotherapy group compared to 10% in the CO2 group. And the authors attributed this difference to the moist created environment and longer healing duration when cryotherapy was used compared with CO2 laser. In the univariate analysis, in our study, the center in Egypt was associated with higher risk of infection compared to the center of Saudi Arabia. In multivariate analysis, there was no significant difference between these two centers. This is most probably because cryotherapy was done mainly in the cases from Egypt, which was associated with higher risk of infection, while in Saudi Arabia center we use almost most of our cases we use dermabrasion. So also, as we mentioned, the role of MKTP site is very clear that lower extremities was carrying the highest risk of infection, followed by foot, then hand and trunk, and the other areas was not significantly associated with any risk of infection. So the current study, the rate of infection was significantly higher in lower limb and foot, and this is in concordance with other studies where the cutaneous surgeries in lower limb was associated with more risk of infection compared with other body sites. In a prospective study, the occurrence of wound infection after minor surgeries was significantly higher in legs and foot. The same in our study. The high rate of infection in the extremities has been explained by lower vascular perfusion in comparison with other body sites, as we know. So in conclusion, soft tissue infection is not an uncommon side effect following MKTP. Risk factors associated with higher infection rate in the recipient area include cryotherapy preparation and treatment done for lesions on trunk, lower extremity, or foot. Using antibiotics seems not to be useful in decreasing the risk of infection. And as we know that as this study is a retrospective study, we need let's say a stronger study like randomized controlled trials to verify these data. And thank you again for your